Hey everyone, welcome to session 206 of the Behavioral Observations Podcast. In this episode, I speak with Dr. Melissa Gonzalez about Pediatric Feeding Disorders, or PFDs, and what applied behavior analysis can offer in this area. Melissa is the Clinical Therapy Director at the Siskin Children's Institute in Chattanooga, Tennessee, arriving there by way of LSU's Clinical Psych program and the Kennedy Krieger Institute, amongst other career waypoints. And in this episode, we talk about how she got into working with individuals with pediatric feeding disorders, what the diagnostic criteria are for this particular issue, what we know what works for pediatric feeding disorders, the difference between picky eaters and individuals with PFDs. We spent a lot of time talking about multidisciplinary approaches to treatment. Man, that's a tongue twister for me today. What the dream team means, so what sort of practitioners do you want to surround yourself with when supporting individuals with these issues? We also talk about, what can you do if you don't have the luxury of a full complement of all different types of service providers. This is a topic that I wasn't particularly familiar with, so I learned a ton. And if you have the same reaction to this podcast, please share it with friends and colleagues. The show notes for this episode will be particularly helpful, and you can find those at behavioralobservations.com and just look for session 206. Or you can just simply sign up for the email list, and I'll send the show notes out directly to you. A lot of folks have told me that they really enjoy getting the show notes emailed to them. They don't have to go surf the net to find them and whatnot. So check it out. It's pretty easy to sign up for at behavioralobservations.com. Okay, before we get to the interview with Melissa, I want to let you know that we are brought to you by abaspeech.org. abaspeech.org is the brainchild of session 203 guest, Rose Griffin. She's given listeners a 30% discount on all her courses, which include the Advanced Language Learner, Help Me Find My Voice, and Start Communicating Today. This offer is valid through December 1st, 2022. So go to abaspeech.org, check out the courses link, and use the promo code ABA30 at checkout to save. We're also brought to you by the University of Cincinnati Online. The University of Cincinnati Online designed a Master's of Education in Behavior Analysis program that is 100% online and asynchronous, meaning you log on when it works for you. If you want to learn more, go to online.uc.edu and click the Request Info button. And last but not least, we're brought to you by HRIC Recruiting. Barb Voss has been placing BCBAs in permanent positions throughout the United States for over a decade and has been in the recruiting business for over 30 years. There's really nobody else in this field who understands the job market like Barb. So if you're looking for a new job, if you're about to graduate, if you're about to move, or if you really just want to know if the grass is greener on the other side, go to hricolorado.com and schedule a confidential chat with Barb right away. You won't regret it. All right, that's it for opening remarks. So please enjoy this really fun and informative conversation with Dr. Melissa Gonzalez.
Welcome to the Behavioral Observations Podcast, stimulating talk for today's behavior analysts. Now here's your host, Matt Sikoria.
Dr. Melissa Gonzalez, thanks for joining me on the Behavioral Observations Podcast. How are you doing today?
I'm doing great. I'm really excited to be here and to talk about something that I'm really passionate about.
Fantastic. We've done a little bit of work on feeding here at Behavioral Observations. When I say little, that's probably an overstatement. We've had some people mention it here and there. We haven't really done much of a in-depth review of what we know about it. So I'm really happy we had the opportunity to connect and have this conversation. And what I'd like to do first, though, I'd like to give the audience a chance to get to know who you are and your perspective and things like that. So why don't we start off by telling us how you got into the world of behavior analysis? How did you discover it in the first place, and what made you want to pursue it as a career?
Okay. Well, I'm from Louisiana, and I was an undergraduate at LSU, and had my first psych class, loved it. Switched my major from occupational therapy to psych in the first week I believe it was. And I had an opportunity to really start to think about, knowing that I liked psychology and having the realization of, hey, I could go get my master's degree or my PhD. I, really started to think about what type of population I wanted to work with. And the children with developmental disabilities had a pull on me. I had some opportunities to work with the ARC and work with some specific individuals who had mild delays, and also an individual who was autistic, and work with them in their home. And it was something that prior to that point I didn't have a ton of contact with, and it just pulled on me. And so I was very fortunate to have some opportunities and meet some people who said, hey, you should check this out. Hey, you should try this. I volunteered at an institute for individuals or adults with intellectual and developmental disabilities, and was able to meet several folks there, and applied to graduate school, and was able to start graduate school. And throughout that course of selecting a specialization of working with individuals with developmental disabilities in a more general context, and that's within clinical psychology, which I think is not as common as you might see in other areas. Through that process, I was introduced to applied behavior analysis. And I remember listening to, he was a school psychologist at LSU at the time, and he was giving a talk about ABA, and I remember just being kind of mesmerized, and I was like, wow, I'm already in this graduate program, and I'm really excited about working with this population, and there's a huge need for it, but I really want to dive into this area, right? I've just been really blessed with having lots of opportunities to kind of meet people and have experiences that just kind of led my way into having really great mentorship and experiences within ABA.
I'm sorry, just to clarify here. So were you able to stay at LSU for your graduate work?
I did.
Okay.
So I was there as an undergraduate. I took a couple years off and then got my PhD in the clinical psychology program. And my area of focus was really developmental disabilities. Also had some crossover work with some of the school psychologists there. And then went to internship, and I went to Kennedy Krieger Institute. And so that's really where things got really focused on ABA. And I had a really great experience, and stayed there for several years after completing my internship, postdoc, and then was faculty there for a period of time. So, very fortunate to be surrounded by really, really smart people who have really great experiences, and was able to learn from them along the journey.
Yeah, so it sounds like you drank deeply from the ABA well, as it were.
I did.
And correct me if I'm wrong, LSU has a particularly strong emphasis on developmental disabilities in their clinical psych program. Is that my memory correct?
Yes, they do, and it's it's kind of a unusual combination, because usually within psychology departments you would find that I think more frequently you see it in school psych departments, but there is our clinical psychology program really has a specialization in developmental disabilities. And so early on, a lot of my experience was actually more focused on adults and assessment, and having a lot of experience with group home experiences, and also in much older adults who were institutionalized at an early age, and had some experience with children. And then really when I went to internship, the predoctoral internship and postdoc, is when I really focused more towards children. And that's when I was introduced to pediatric feeding disorders on the feeding program at Kennedy Krieger, and also had some experiences on the neurobehavioral unit as well while I was there. So just lots of really great experiences, lots of good around really smart people, and was able to learn a lot.
Oh, I can imagine. Very cool. What? So we were chatting just before we hit the record button here, and you said
Sure.
you're in Chattanooga now. So how did you?
Yeah.
What are you doing these days in Chattanooga versus what you were doing out in Baltimore at Kennedy Krieger?
Right. So I was at Kennedy Krieger Institute in their Pediatric Feeding Disorders program, where I worked on their interdisciplinary team. And so I worked with children who were admitted as inpatients for pediatric feeding disorders, also worked with children who were in their day treatment program, and also experiences related to outpatient services there. But most of my work was really on that more intensive end. Many of the children that we would see were referred, had not been very successful in a more outpatient traditional kind of experience, and were coming in for a 6 to 8 week intensive program to really work on their feeding skills and advance their oral intake. Oftentimes these children had some medical complexities, and we worked with a really large interdisciplinary team. I was there for quite a while and learned a lot, really loved being there. But as time went on and as my family grew, we decided to move for family reasons. And so I have moved to Louisiana for a short stint and did some work there for about 2 years prior to moving to Chattanooga, Tennessee. And here I'm working at Siskin Children's Institute, which is a nonprofit organization. And our mission is to improve the quality of life for children with special needs and their families. If you would have asked me where will you end up or where will you be, 5 or 10 years later, I would have never said Chattanooga, Tennessee, but I have to say I love it. It's beautiful. You're close to lots of nature, and it's, very nice for a family life. And so a colleague of mine that I met in Louisiana, had found this opportunity, and she was like, "Hey, why don't you come with me? Come check it out." And I found this gem. It is a really wonderful organization that has folks from lots of different perspectives and disciplines that are all here for the same mission. And so we have developmental pediatricians here, which are, really hard to come by within the United States. We have occupational therapists, speech therapists, behavior analysts. We also have an early learning center with special educators and in-home early interventionist. And so just, really have a wonderful organization that has the heart to serve families and to improve their quality of life. And so, it's just been a wonderful fit and a great opportunity to be able to share some of my experiences that I've had in more highly resourced areas, right, with an area that is underserved and that there aren't as many resources available for these families.
I see. And again, I'm sorry if I missed it, but what is your role there?
I'm the clinical therapy director. So I work really closely. So we have several different pillars of our organization. One of those pillars is our Pediatric Developmental Center, which is an outpatient services. And so I oversee the therapy services that happen under this pillar. And I work really closely with our medical team.
Hey everyone, we got a lot more to get to in this interview, but first I want to take a quick break and talk about the Advanced Language Learner course from abaspeech.org. Do you ever work with students or clients who very quickly learn their first man's tax and other short phrases only to see them plateau shortly thereafter? Well, ABA Speech, the brainchild of Rose Griffin, who's both a speech-language pathologist and BCBA, has just launched her new course, the Advanced Language Learner. The Advanced Language Learner course gives participants a proven, easy-to-follow, and fully customizable framework to use that will help you take your learners to their next steps in their communication journey. So who is an advanced language learner? Well, someone in this profile uses phrases spontaneously for a variety of reasons throughout the day. They might label some items and actions on their own. They engage in some parallel play with peers, and they're about a level 2 or 3 VB-MAP learner. And yet these learners seem to be stalled in their progress. So if you have students or clients who need help advancing their communication repertoires, check out the Advanced Language Learner course. It's important to emphasize here that this is not a quick webinar or recorded Zoom call. With the Advanced Language Learner course, you'll get 5 hours of on-demand instruction, 5 downloadable resources, and 9 demonstration videos. And you not only get the course itself, you also get the Advanced Language Learner Goal Bank, a library of adaptive books, access to monthly group coaching calls, and of course, CEUs. It's good for 5 BACB-A CEUs and 0.5 ASHA CEUs at no additional cost. You have to complete a short quiz after each module, but it is of no additional cost. So for more information, check out abaspeech.org and save 30% off your checkout using the promo code ABA30. Very interesting. I've heard that area of the country is just really neat. So hope to get out to visit someday. But for the
Please
time
do.
being, yeah.
Let me know if you get. Let me know if you get here.
Yeah.
I'd love to introduce it to you. So
yeah, that's one of the fun things about doing the podcast. You get to talk to people from all over the place. It's like, boy, there's a lot of cool places that are on my list to visit. So, but for the time being, we're chatting via Zoom, and we're I want to talk to you about feeding. And I realize I've got a bunch of questions here, and I realized as I was writing out the questions of like what all the things I want to know about it, I'm thinking to myself, this could be like a graduate course. So I realized that the questions I'm about to ask are like incredibly unfair, and I'm not expecting like a dissertation level response. I'm more so looking for just kind of general ideas about this topic, so that our audience can familiarize themselves with this area that that frankly we don't really run into all that, or many of us aren't really adequately trained in, and all those things. So I guess what I'd like to do is just start off with some basic terms, and so if you can just kind of give us an overview of like what constitutes a feeding disorder. I'm sure there are variants of feeding disorders and things like that, but let's start off with some definition of terms here. So if you can
definitely
give us a rundown of some of the more common things that people struggle with in this area, that would be great.
Yeah, so I think that's an excellent question, and there's been a lot of movement within the area of or with organizations who really focus on pediatric feeding disorders. There's some really nice organization that's happening and movement in terms of advocacy groups and also clinical folks or medical folks within the field to kind of leverage and make information more available and awareness of these issues. So in 2019, a group of providers, including GI docs, developmental pediatricians, folks across disciplines, wrote a consensus paper on pediatric feeding disorders and clearly defined what that is. And what's really great about that is because prior to this, every discipline kind of had their own definition of what that would be, right? So you had the speech language pathologists kind of defining it in a certain way and calling it dysphagia or calling it some terms. You had the GI folks or the medical folks referring to it with different medical terminology. And so we finally have a consensus definition that can be used across disciplines. And that's so important because of the multifaceted and complexities of pediatric feeding disorders, that really having a common language goes a long way, not only in communicating across disciplines, but also advocacy and communicating the needs of these families and these children, and also kind of being able to communicate with funders related to what are we talking about and who are the right folks to be helping these families, and just kind of really leveraging some great advocacy work. So a pediatric feeding disorder, according to GADE, which is the 2019 consensus definition, is that it is a child who is not having 2 or more weeks of not engaging in age-appropriate eating that is a result of medical, nutritional, skill-related, or psychosocial factors. And that consensus definition article really goes into detail about the specifics of what these types of symptoms might look like. And some of the key factors here is that you don't necessarily have to hit all of them, but there's a it's a combination of, or it's issues that are happening across these domains, okay, that qualify it as a pediatric feeding disorder. So I would recommend that anyone go out and look up GADE 2019, and I'm happy to send you the link for that article that maybe we can put with the podcast that really goes into some nice detail about how, kind of what is the current definition of that, and how does this present in children, and how different disciplines might be looking at different types of symptoms that kind of converge together to create this disorder. feedingmatters.org, which is also an advocacy organization, they have been putting out some really nice kind of public information, and really it's put out for primary care physicians to screen and kind of define what are some of these symptoms. I'm happy to also share that with you to include with the podcast, because I think that could be helpful for your readers.
Okay, we're going to take another quick break here and talk about the University of Cincinnati Online. Balancing work and life can be difficult, and that's why the University of Cincinnati Online designed a Master's of Education in Behavior Analysis program that is 100% online and asynchronous, meaning you log on when it works for you. Their student success coordinators will work with you from the start all the way until graduation to ensure you are receiving the support you need. You can graduate in as few as 5 semesters from a top 10 program and total number of graduates and prepare for the BCBA exam. The program is FAFSA eligible, and UC also offers a business partnership program to offer tuition discounts to eligible employees. If you want to learn more, go to online.uc.edu and click the Request Info button. Disseminating that information out to pediatricians sounds almost kind of like how, if we went 10 years ago, in a time machine, how like the awareness for autism spectrum disorders more generally, was disseminated. So in other words, there were probably certainly there still are, but kids are kind of going under the radar, going undiagnosed.
Yeah.
And I imagine the same thing is that's happening with feeding disorders, and perhaps it's even more ubiquitous. I'm guessing, correct me if I'm wrong, because, there's probably a tendency to say, well, he's a picky eater, or there's probably a bunch of, old wives' tales that get unfortunately disseminated as it relates to these sorts of things. And so the opportunity to correct that misinformation must be helpful.
Yeah, I'm so glad that you mentioned that. So in 2021, there's an article put out that said that 1 in 37 children under the age of 5 qualify for a pediatric feeding disorder. And it shocked me that it was that common, right? And so I think, yes, it is. It happens. It is quite frequent that children have difficulty with eating, and the earlier that we're able to intervene, I think the better course that it is for the child and the family. And it is a concern, a pediatric concern that folks just don't talk about or realize. And you're exactly right, Matt, that there's these old wives' tales of your child will eat when they're ready, or they'll eat when they're hungry, or of course, isn't that just a normal process that humans do, right? And actually there's a lot of ways that feeding can go wrong, and I think that would be good for us to probably hit on in terms of, how do these things come up, and what does it look like when it's not addressed early? I think is really important.
So we have this 1 in 37, and that's everybody, right?
That's under the age of 5.
Yes.
And that is a recent article in 2021. It was a prevalence study that was conducted. That number was higher than what I expected it to be quite honest. But I think that there's a lot that are going under the radar and that are not addressed. And then now that I'm in more of an outpatient mode, I'm seeing these kids at 9, 10, and 11, and most of their diet is Pediasure or Ensure. And so these are just things that were not addressed early on.
I see. I was going to ask you, one of what happens when these problems aren't effectively addressed. I guess that's one of them. Where you get like no diversity of food intake whatsoever, and you're subsisting on things like what you just mentioned. Can you get into that a little bit more? Because I'm sure you see a whole host of negative or deleterious effects from people not getting the feeding aspect nailed as parents, or adequately dealt with, I guess I should say more.
Yeah. And, I think, I guess to also, I think some of the things that need to happen in order for this to be better dealt with, and hopefully the advocacy that some of these organizations are doing are really going to push us towards that. But, there's not a whole lot of specific training that pediatricians generally get about these types of concerns. And so, I also think that there's a lot of misinformation and parents are often brushed off when there's concern. So I think probably thinking about this in terms of, okay, what is typical feeding development? And then let's talk a little bit about how things go awry, and then what will it continue to look like? And that might be a good way to address some of that questions. Is that okay with you if I kind of take it that way? So, I think one thing that we need to distinguish pediatric feeding disorder is pediatric feeding disorder versus picky eating, right? And I think sometimes those are confused. And I think it's important for folks to just recognize and be able to attempt to try to distinguish. Picky eating is a phenomenon that we see with children between the ages of 18 months and about 3 to 4 years of age. And this is kind of a evolutionary developmental phenomenon that's pretty common. You see it more problematic in some children than others, right? So there's a range of the way that this presents, but often it's neophobia, or I'm afraid to try something new, or I kind of want to just stick with the foods that I always stick with. And that is kind of a developmental pattern that is commonly seen. If we think about it from an evolutionary standpoint, probably made kind of sense, right? 18 months, we're moving around, we're maybe with our parents foraging in the jungle or in the forest, and we need to be careful about not eating every berry or every mushroom we pass by, right? So there's probably an evolutionary reason why this occurs. The difference between picky eating and a pediatric feeding disorder is that picky eating doesn't result in significant concerns related to a child's weight. It doesn't necessarily result in the child eating, fewer than 10 foods. It doesn't mean that they're only eating foods from one specific category, right? So there's still some variety, though maybe we're hitting on the same couple of fruits. So they're not eating, 10 fruits, but they're eating 2 fruits consistently, and we're feeling good about that. Their growth is good. Usually it's transient, right? So it's not something that's kind of, they're not losing foods from their diet. There might be some variability from day to day of what they're eating, although, meal times might be a little bit more of a struggle. On the other hand, pediatric feeding disorders, usually there are concerns related to the child's weight. There's concerns related to their dietary variety and their vitamin intake. This is something that oftentimes you'll see children who are losing foods. So rather than it being variable, the number of foods that they're eating are decreasing, or they're just very, very limited from the beginning, right? You may see children who are requiring they're getting the majority of their intake and nutrients from a liquid source, whether or not that's Pediasure, Ensure, juice and goldfish crackers, right? So there's a little bit of a distinction there, and we often see that kids that are in the kind of pediatric feeding disorders, that this is something that isn't improving over time, right? It doesn't. It's a phase. It's a little bit more of a stable process, and you usually start to see continued. Things are not getting better.
I see. Yep.
Mm-hmm.
What is the process for assessing, not just why these things are happening? Let's talk about that first, I suppose. Let's talk about how do you figure out how do we get here, if you will, because there's sounds like there's there's obviously some behavioral components to this, but there may, but you also alluded to the multidisciplinary aspect of this work as well. So how do you figure out like what's actually going on here before we start conceptualizing treatment?
Right. So, I think we know that there's certain conditions that kind of pose a risk factor for developing a pediatric feeding disorder. So things like prematurity, because, and if you think about it in terms of what are the typical developmental sequences for learning to eat, when a child is premature, requires NICU, maybe requires oxygen, supplemental oxygen or intubation early on, those early experiences of having these not so pleasant things come towards your nose and mouth, right, set the stage for breastfeeding or bottle feeding to not go as it typically does, right? And so those early learning events are early events of having of eating or having kind of rooting with the mother or with a bottle, don't result in necessarily pleasurable experiences, right? So we have this kind of aversive conditioning that's occurring, right? And so prematurity is a risk factor because of that early aversive conditioning. Children with cardiac concerns, because oftentimes their caloric needs might be higher due to their cardiac concerns, and so just the ability to keep up. And so oftentimes those kids may require an NG tube as a young infant. Children who have reflux or a number of different medical conditions related to the GI tract. So they're considering that there could be pain associated with their eating that is maybe immediately after eating or shortly thereafter. And so you have this pairing of discomfort with following during or following feeds. So those are major medical issues that might be a cue that if the feeding trajectory is likely not what the typical feeding trajectory is, and because it's a little bit off the normal trajectory, sometimes that will then snowball into more concerns. So for example, let's say that you have a child who has reflux as an infant. Usually it takes a little while for us to figure that out, right? And have that effectively treated. And so even once it's effectively treated, you have that aversive conditioning that's occurred. Plus you may have some skill development that is lagging behind the normal progression. Right. And the longer that there's a gap in terms of feeding, getting back on that trajectory of it being a positive experience, oftentimes you see the greater lag in that skill development. So you have a medical condition that was the impetus of the problem. We've now have this new trajectory that isn't the typical feeding trajectory. Because there's this is an unpleasant experience, and maybe this is something that the child is not willingly doing, we're not gaining the necessary developmental skills to be able to move through the typical feeding stages, right? And so there's skill difficulties. And then in the meantime, caregivers, you're like, that's a basic need, right? So as a parent, I mean, Matt, you're a parent, right?
Mm-hmm.
And I know it's been a while since your children were infants, but, one of the major jobs that you have as a parent early on is to make sure your child is fed, right? And when that doesn't go well, oh my goodness, that is a very stressful circumstance. And parents are willing to do whatever it takes to get that child to eat, right? And so then we start to see the dynamics of the caregiver and the child. Things change, and sometimes some of our efforts to ameliorate that situation over time may not be the most adaptive overall. So I think, really, go ahead.
I'm sorry. I could just see a situation, and I see it on a less severe level, I suppose, with some of my friends who have younger kids, where the kid is absolutely shaping the behavior of the food preparation, and this mainly revolves around the choice of what they eat and also where they eat. But yeah, it's like the kid is definitely training the parents big time. Right.
And for a while, or in the literature, you would often try to see folks trying to make these categorizations, right? Oh, well, it's a behavioral feeding problem, or it's a skill-related feeding problem. Oh, or it's an organic or non-organic feeding problem, right? But in my experience, and I certainly only have my experience to pull from, right? I don't know everything, but in my experience, more often than not, it is a mismatch of all of these things, right? It is not very clear cut in that you can put it in a bucket of okay, what this one is skill and this one is not. I usually find that there's a combination of these factors that are at interplay, which makes it so important that we have a good team surrounding the child and the family to support them, because it's oftentimes a combination of these factors that come together to really cause the problems that I see when the child is maybe 2, 3, 4, 9 years old, that have kind of snowballed over time.
Everyone, last break of the podcast, and this is for HRI recruiting. If you are graduating, if you're moving, if you are not happy where you are, you're thinking about some other potential employment move, there's nobody in this business who knows the ABA job market like Barbara Voss. She's been a recruiter for over 30 years, and she's been in the behavior analysis world for about a decade. She really knows her stuff. So what you're going to want to do, if you're in this circumstance that you want to see what's going on elsewhere, explore some options, go to hricolorado.com and schedule a confidential chat with Barbara right away. You won't be disappointed. All right, let's get back to the conclusion of this episode. What might be helpful perhaps is if you can walk us through kind of a representative case, if you will, because I'm curious about how we find out. You're just mentioning a number of possible complicated, ramifications of early medical histories or even current medical challenges and things like that. So I'm curious about how the various team members go about doing their part as it relates to figuring out, is it like I have to imagine there's like probably an exhaustive, kind of parental interview and mining medical records and things like that. So I don't know if it would be helpful to, again, walk us through a representative case that would give us a quick thumbnail sketch of each one of those team members' kind of responsibilities. And, that might help conceptualize this a little bit better for the listeners.
Certainly. Before we dive into that, one thing is I feel like I kind of dove into the medical issues, but I would be remiss to not say that developmental conditions greatly increase the likelihood that the child is going to have a pediatric feeding disorder. So I know we kind of started out with the medical piece, those early medical conditions, but it is very common for children with developmental delays, if a child has any craniofacial or anatomic abnormalities, autism. It's very common to see children with pediatric feeding disorders. And oftentimes those symptoms start to emerge around the time that the parent is starting to be concerned about their child for autism. So I just wanted to make sure to broaden that array for us as we talk about this, is that,
Thank you.
Yes, early medical conditions are often a predetermining risk factor, but also if you have any developmental conditions, those are also very clear risk factors for developing a disorder. And sometimes you'll see overlapping medical things with that, but sometimes you won't. And it may be that the child has increased sensitivities to kind of sensory experiences, or has this insistence of sameness and routine that may have an interplay with their feeding preferences, and thus result in highly selective eating. So just to broaden that array for us.
Thank you. Yeah, that's helpful. Yeah, and I'm glad you gave different examples. Sometimes we use the word developmental delay almost synonymously with ASD. So I'm glad you mentioned some other aspects of the DD that fall under the DD umbrella. Certainly they could lead to this. So I appreciate that elaboration.
Oh, great. So in terms of what initial intake might involve, and I know that you wanted me to kind of outline what are the different roles on the team when we do that. And I think in some ways it kind of depends on what disciplines you have on your team, right? So I think in an ideal team, we'll talk about an ideal team, and then we'll talk about, reality, what happens sometimes, right?
Okay.
Because
all right.
So I find that sometimes, depending on where you are in the country and what your resources are, you may not always have access to your dream team. And so you try to put together a team the best you can and make sure that you're making connections. So a dream team would be having access to a gastroenterologist would be awesome, or a developmental pediatrician. Those are the two medical folks that are most often associated when you see large feeding teams. At Kennedy Krieger, I was very fortunate to be able to have that person on the team in the room with us when we did some of our intake. Since I've been moved to more rural areas in the country, that is not as easy accessible in terms of having it in the room with me, but I always make sure that I make connections in the community and make sure that I have a dialogue with those community providers and or communicating with them if we're not together for that assessment. Also in the ideal dream team, I would have a dietitian. I think that is very helpful in terms of looking at what is the nutrient intake for the child, what is the growth parameters, what are the expectations, and also making sure that the family has good expectations on what their child should be eating at that specific age. Again, dietitians are really not I haven't found super easily accessible. So that would be one. If anyone knows a dietitian in Chattanooga, let me know, because there's only a few here and they're highly coveted. And so, if folks are thinking about career decisions and you haven't made that decision yet, something to think about. Also having an occupational therapist and or a speech therapist. And then obviously someone that has some experience with working with behavioral coaching or behavioral parent training, also behavior analysis, all of that would kind of go under that psychosocial piece. It's also really helpful and on a dream team to have a social worker because as we alluded to before, this is a highly stressful family concern that can really result in a lot of guilt and just really high levels of caregiver stress, depression, anxiety, and just daily challenges. And so having someone who can just support the family with that emotional toll that this can take over time, it would be really helpful. Now, then again, that is the dream team. Is the dream team available in all places? No. So you have to kind of figure out how to make your team. In terms of that intake interview, what I and what the teams that I've worked on in the past really want to have a good developmental history and a good medical history. So we want to be sure that any ongoing or potential ongoing medical issues are being addressed or resolved, or at least for us to know the status of that. So you're going to want to know, does the child have any food allergies? Is there any potential for that child to have food allergies? Have they ever had any reactions? In terms of their GI, potential GI conditions. So, do we have any concerns about the child potentially having reflux that maybe is not treated, or eosinophil esophagitis, which is a little bit tricky, and I'm not a medical professional, so I don't want to dive in it too quickly, but essentially it is a reaction that a child would have to a food, but it's not usually an immediate reaction. It is a delayed reaction, which can sometimes make identifying that food culprit really, really challenging, because maybe the child has to eat a certain amount of that before their body is triggered, and it's not immediate. And so sometimes that is kind of like a sleeping medical issue that oftentimes may not be readily identified. We also want to get a good sense of what is the child's respiratory history. And again, the medical person that's on your team or the person that you're consulting with, if the child has a history of lots of respiratory infections or a history of pneumonia, then we may have some concerns about the child's swallowing function and their safety to do that. Aspiration would be one thing that we would want to be asking questions about or looking at. And our speech language pathologists, actually our speech colleagues, have really great training in terms of swallowing function. I do want to kind of qualify that in that just like every behavior analyst doesn't have experience with feeding, not every speech language pathologist has a love for or in-depth experience and training for feeding or swallowing. But typically when you're looking at airway and swallowing function, the speech folks are usually that the discipline that's going to be looking at the child's safety for swallow and if there's any concerns for aspiration. And that's when food would go down the airway rather than the esophagus, right? Which could be very problematic and lead to pneumonia. So that's why we ask about respiratory history and history of pneumonia. Asking about constipation is really important. That is a conversation that I have with families regularly. I think sometimes it's the chicken or the egg, right? Like, so why do they have constipation? Well, they don't have a great diet. Well, why don't they have a great diet? Well, because they're constipated and they're full and their belly hurts and they don't want to eat, right? And so really having a good collaboration with that medical provider and making sure that we're actively treating constipation and providing guidance to the family and how to effectively manage that is very, very important. So those are some of the most common medical or kind of medical symptoms that you're going to be asking about, or the medical person would be asking about. But you're also going to want to just get a good sense of, how was the child? How was the pregnancy? How was the birth? What happened shortly after birth? And just get a good medical history in addition to a good developmental history. Obviously, the more complex the child is in terms of their medical history, that's when you're going to really want to make sure that you have good communication with a medical provider to be providing some guidance on what are some potential factors or things that need to be considered that might be outside of the scope of the behavior analyst. The dietitian, or myself or the dietitian, I usually like to get a good sense of what is a typical daily intake for the child. I might ask a family to complete a 3-day food log, or just tell me within the clinic what did they eat yesterday, and let's go through that. How typical of a day was that? It gives you a sense, how much variability do we see with that? That will give you a sense of dietary variety. How much volume they're taking in, kind of always thinking about, are they drinking enough fluids? Are they specific in how they drink their fluids? So if a child is very restrictive in terms of, I only drink X out of this particular cup, right? Then that is concerning, right? Because if we're not able to get fluids in the child, then you can become dehydrated and have to go to the ER pretty quickly, right? And so how I might think about that, or who I want to be in contact with, that might change depending on how restrictive we are about how we're getting our fluid. So always just thinking about, are we getting enough fluid? Not getting enough fluid will also lead to constipation, which is going to be a barrier for me making any type of behavioral change, right? So really just getting a good sense of what is that dietary variety. That dietitian would be really great at doing nutrient analysis and letting you know whether or not we have some concerns related to the kind of the different nutrients that the child's receiving. Occupational therapy and speech therapy. I've worked with folks in both of those disciplines who've had different experiences and kind of specialize in different areas that tend to cross over. So I think some of that may be very specific on that clinician's training, experience, mentorship, and background. But our occupational therapists and speech therapists are often really helpful in terms of developing chewing skills, assessing whether or not the child is showing developmentally appropriate chewing skills, what types of textures would be appropriate to present that child based on their skill level. As I alluded to before, the feeding problems tend to be somewhat of a snowball effect, right? So things get disrupted, and then before you know it, because we haven't been practicing this thing and avoiding it, we're not gaining the skills that we need to, and then all of a sudden you're behind the 8 ball in terms of your skill development, right? And so really having a good sense of what types of textures is a child willing to eat? How effective are they at that? What happens when you give them a more challenging texture? And how much of this is preference versus skill? And like I said, oftentimes there's some crossover there, right? But knowing that as a clinician and the behavior analyst is very important, right? And sometimes that's something that if you don't have that speech or OT there, or don't have that personal experience yourself, can be easily missed. And you may end up trying to work on a target that may not be kind of developmentally where we should be starting. And then finally, as the behavior analyst or psychologist, I want to see the dynamic between the caregiver and child. I want to see, what does it typically look like at home? What are those interactions? What strategies is the caregiver using? How does the child respond to those strategies? What is the caregiver's expectations? Is it developmentally appropriate? And so that kind of gives you an idea of what an initial assessment might look like, and how the different folks might play into that.
Okay. All right. So that sounds like a very comprehensive review. Yes. from the dream team. So I guess before kind of walking through a case study, it might be interesting to see to let us know how that might look when you don't have the dream team. So let's just say you have a behavior analyst and maybe a pediatrician or some other person who's more, shall we say, commonly available, or more likely to be on a team than not. You reference some number of professionals being harder to find than others, and so in the absence of this super wonderful, awesome team, how would you proceed trying to figure out what's going on with the kiddo who's presenting with a pediatric feeding disorder?
So my go-to is I would definitely want to have a speech path. That would usually be the one that I would probably want to make sure that I have available. And the reason for that is I think that they have those who are interested in feeding and have that training and experience are really skilled in terms of their knowledge of swallowing function and safety for swallowing function. And though I've worked alongside speech paths and have learned a lot from them, I always feel like I need to have a speech path for sure. Okay. So that would usually be my go-to ask, and perhaps an OT, depending on that OT's training and background. And so currently we have in the place that I am currently, I have access to a number of different disciplines, but I don't necessarily have them all in my initial assessments. And part of that is just resources and availability and making sure that we're able to effectively and efficiently serve families. But I do consult very heavily with my speech path if I have any concerns related to their ability to swallow or has respiratory history. I think for folks who maybe don't have as much experience with dealing with feeding, I think having a speech or an OT to kind of examine the child's chewing skills would be really important. Okay. Because I think that that's something that takes a lot of just exposure experience and seeing that across lots of different children to get a sense of, okay, wait a minute, we may need to go back and look at this. Not something that you can just read about without having a good amount of just experience, clinical experience.
I see. So it sounds like having someone there to assess the chewing and swallowing and the skills is the must-have, if you will, if we're going to use that.
That and also the medical clearance, right? Yes. So like before, I require that there's medical clearance from the PCP or a GI doc prior to scheduling any initial evaluation. So at least I know that someone has at least, looked at some of these major issues, and I still ask about them after in my interview. And if there's any issues that still come up, I might then go back and talk with them and say, hey, I just want to double check. Do we feel really good about this? Mm-hmm. So medical clearance from the outset, and then maybe consultation with a speech or an OT.
Got it. Mm-hmm. And so what would the functional assessment look like for, let's say you've kind of ruled all the medical conditions out, the other related service providers have weighed in and deliberated on the individual's case and whatnot. How would you go about assessing what's going on from a behavioral perspective? So when you get in there and, all right, I'm going to do my thing. What is your thing? What does it look like? Let's take it from there.
So I usually start out with a descriptive assessment, and really try to get a sense of what does it typically look like with the caregiver and the child, and not only do some observations, but also ask a lot of questions about what does it typically look like at home? What do they find successful? How does the child typically respond? I also really try to watch the child when presented with something that's preferred, so I can look to see what skills are they demonstrating when it's something that they're used to, it's preferred, it's something that is not a huge challenge. And then also when it's something that's maybe less preferred. And again, there's different dimensions where I might pick up different things there. I might be able to observe how they respond in terms of their acceptance or refusal under those circumstances when they're presented with a preferred and non-preferred, but also might be able to get a better sense of how they're manipulating the foods. Are there potential skill concerns? Are there any other kind of very specific feeding skill things that I'm gaining from looking at something that is relatively easy for the child versus something that's more challenging? When I was in a more highly resourced environment, we would do functional analyses and really look at the different factors that might be maintaining the food refusal. Currently, I really look at kind of that interaction between the child and the caregiver, and also typically follow up with some simple kind of structured ways of presenting food that I have good reason to believe that they're able to take, right, from a skill perspective. And so that might just be a very structured way of presenting that food, depending on the age of the child and the developmental age of the child. That presentation might look very different. But just seeing, okay, if I add some structure here and set a very clear expectation, let's get a sense of how they respond when that's presented. How do they respond when there's lots of bells and whistles in terms of reinforcement and just kind of environmental contingencies, and just getting a sense of what are the different am I seeing the child respond in the same way across all of those conditions? Am I seeing, are there differences in the way that they respond? When I vary the level of demand, am I seeing differences in the way that they respond? With feeding disorders, we have a good amount of literature to indicate that most often, at least within the published literature, that refusal is often maintained by escape from the demand or escape from the presentation of the food. Now, oftentimes there might be some combination of things that are happening in terms of the child's the caregiver's attention, or being pulled away from preferred activities. But the literature base provides a good amount of data there to indicate that oftentimes the refusal is more of an escape from demands. And so I try to really be able to capture that within an observation that is very close to what's going to happen at home, or what maybe the beginning parts of my treatment might look like. And that's kind of where I move from the descriptive analysis.
Got it. Do you find that there's a kind of a sequence of reinforcement in terms of, the non-preferred food is refused or expelled or what have you, and then the parents they got to eat something, so here comes the mac and cheese, or here comes the Cheez-Its, or or what have you. So I'm wondering if you see things like that. So there's this kind of cluster or array of sequential reinforcers that are happening.
Yeah, I think I think the thing that makes feeding difficulty so interesting is that you see children of lots of different ages, skills, and kind of points that are presenting with the same problem. And so, yes, I think, yes, you often do see that. But you also see some children that it doesn't matter what it is that's coming to them, they are refusing it, right? Okay. If it's not on their own terms, or if it's not, if they're not bringing, so I think you see a lot of variety in terms of how this happens. I think sometimes you see caregivers who, particularly in the outpatient setting that I am now, not really sure how to provide a little bit of increased structure to support children in terms of accepting foods, or being supported in terms of trying things that might be new, right? Maybe their expectations, or I just put the plate in front of the child and they eat, right? And so I think, in terms of how we get started and look at some of those factors, I think they're very family dependent and very individualized. And I think that you may see some things that are depending on the child's history and their medical history and or developmental history. You'll see very different patterns from family to family and from child to child. And so that individualized assessment and kind of starting from where the parent is and what typically happens, I think, is kind of the key point of starting, and then kind of going from there.
Okay.
That answers your question. I feel like it's not a very specific answer, but I feel like there's a lot of variety there. So it's hard to kind of just saying, it happens this way.
Of course, I understand. So when you're doing these observations, are you bringing the parent and child dyads into a clinic setting to watch them eat, or are they submitting video, or and also is that the same as it relates to treatment?
Combination of those things. I think oftentimes the first time that I see a family is in the clinic in person. And so probably those first that first observation might be, hey, I just want to see what this looks like. And I ask families to bring food from their home. I also have food here. And I just say, hey, can you show me what this looks like? So oftentimes it will start there. Once I start working with a family, depending on what we're seeing in clinic and depending on how well that might be going, we might use telehealth as a tool to be able to observe what it looks like at home. We know that sometimes children respond very differently as a result of just being in a different context or being with a new person, or maybe just the transition to get here in itself may set the occasion for things to go quite differently than home. And so I do use telehealth as a tool to be able to get that. And, in an ideal world, we'd be able to do a lot via telehealth, right? And I found that with some children, actually, a lot can be done via telehealth. It's the setting in which their meals are happening all the time, right? And if I can do a little bit of coaching and supportive, then it works great. Other families, there's barriers, and being in the clinic may be a better route for them.
So if a lot of these repertoires are, hinge on escape, what is your approach towards treatment? What are you trying to set up, at least in the clinic, and what are you asking parents to do when they follow up at home when it's time to when it's mealtime? Right.
So as a person who sees patients on an outpatient setting where, families may not see me for another week, I'm really always thinking about how can we create some routines that are aligned with what the family can do at home or are already doing at home, and it be successful, and also hopefully advance the scenario, right? So kind of how can we push the child a little bit outside of their comfort zone, but in the zone of learning, right? Not in the zone of panic for the child or the parent.
Okay.
So, within clinic, when I'm having my sessions, I'm usually try to be 2 or 3 steps ahead of what I'm asking the parents to do at home. So whatever I'm doing in clinic and trying to work with a child in clinic, usually I'll say, okay, I'll try to dial it back a couple of steps and have them practice that at home and really start to begin to think about how can we make that part of their daily routines, right? Because we know that a lot of the work of outpatient work is what's happening in between sessions, not necessarily in my weekly session with them. In terms of my approach in clinic, I'm usually trying to assess and determine, okay, how can I have this child feel comfortable, be comfortable with this scenario that maybe historically has not been a very comfortable scenario in terms of just the idea of mealtime or the idea of food is going to be presented to me in some sort of way. And how can I identify where is that cusp where we can work on routine or some type of interaction that's going to be tolerated without a meltdown or without panicking. And so sometimes that might even be an empty spoon to start out with, right? And to really try to encourage those routines for short periods. And the goal is success, right? And repetition of success, and then gradually shaping and fading and building on that. For really young children, sometimes the idea of just an empty spoon is also upsetting to them. So, we might just be working on kind of slowly introducing that spoon near and around them to the point where they're not becoming distressed, right? And then once we get that tolerance there, then we might start to increase our expectation of how that presentation goes and how that's accepted, and providing reinforcement related to that. Sometimes we're using non-contingent reinforcement just to kind of keep this a happy kind of calm environment, and pair some positive, pair some reinforcers with a scenario that maybe historically hasn't been a very positive experience for the child. And then also providing contingent reinforcement for meeting specific targets. And then always thinking, okay, how can I have the caregiver start to begin to have some of this as part of their routine, and that it's going to be successful. So I'm building the capacity of the child, and I'm building the capacity of the caregiver, and that this is no longer a stressful daily event for them, but something that's positive that we can continue to shape.
I see. Okay, that makes sense. So I'm hearing some either shaping or fading, and as well as some non-contingent reinforcement and some direct contingency, first then type of relationship. So that all should sound pretty familiar to the audience for sure. And it sounds like, and correct me if I'm wrong, sounds like you're also monitoring the situation such as to keep the escalation level at low or at bay altogether. Is that fair to say?
Yeah. I mean, I think that's over time. Yes. I think as I'm, and, as we see in the literature, I think it is, when you're in a more intensive program and there's lots of supports and resources, I think there may have been different ways of going about that. But certainly, as I find myself as an outpatient sole provider, knowing that my goal is to make this scenario a not stressful scenario for the family and for the child, and something that could be part of their daily routine, at least the start of a daily routine for them. Yeah, my goal is to not get to the point of meltdown or escalation. Now, am I always successful at that? No, but that is my goal, and I am, always looking to see, okay, how can we have this child learn to be able to regroup, learn to be able to feel okay being pushed a little bit outside of their comfort zone, but not pushing it so far to where we're getting this huge extinction burst or this really stressful event for the child and the family. I
see. Very good. So tell me a little bit about what are some. So it sounds obviously, you see an individual once a week, and the majority of their meals are taken outside of that time. So, what are some tips that you've found are helpful in getting caregivers to follow some of your suggestions, instructions, et cetera?
One thing is the small bites. Small bites are really helpful, and I don't mean. I guess that's a pun that I didn't really intend. Yes, but I think really thinking about what are realistic expectations for the family and the caregiver, and maybe practicing a new routine is not going to be successful for every meal, and certainly may not be successful for family meals, or realistic for family meals, or when the caregiver is being pulled, has multiple things that they need to attend to. So I think that one thing that I typically recommend is, if we are working on some routines and asking the family to work on something that might be a little bit new or a little bit different than what they typically do, I usually say, let's do this during a snack when it's just you and the child, not at family mealtime. Mm. And the reason that is because, it's hard when there's a lot of people at the table, giving lots of advice or having lots of reactions to what's happening. And eating is a very cultural part of our existence, and we all have opinions of the right way, the wrong way, or what's how to do that. And you even see parents maybe disagree about what's the right way to do that, right?
We could do multiple podcasts just on that alone, for sure.
Right. Exactly. I mean, whether it's extended family members, neighbors, whatever, everybody has their idea of what's the right thing to do. And so that's probably not the greatest environment to ask a family to practice something new.
That's such good advice. I'm sorry to chuckle, but I could just imagine how that would go down in various scenarios that I'm familiar with. So yeah.
Yeah, definitely. And then also, family mealtime is a social time. Mm-hmm. Hopefully it is something that it's going to be a relaxing and time where we're sharing about our day. It's not the time that we want to, start practicing a novel strategy or novel routine. And so really always keeping at the forefront of your mind that this is a highly stressful scenario for the child and for the family. Let's be very wise about when we're recommending that they are doing this, so that they can be successful and feel good about it, and that they actually engage in the practice, right? Mm-hmm. Also making sure that whatever routines we're recommending, that we are putting some time limits on that, right? So we're giving a very clear expectation of what the practice should be, how much that should be, and at what point are we just going to say, okay, this is done, we're moving on with our life, right? Because I think, things might happen one way in the clinic, but they may look very different at home because of the history, this child, and the maybe stimulus cues at home that, bring about responding that's different than the clinic. You want to make sure that you're giving that caregiver or whoever's supporting that patient a way out of that they feel good about, and it's planned and it's decided before the practice, right? Kind of a exit strategy if things don't go as maybe predicted. And really just starting really, really small and seeing how does it go at home when I'm not there? How can we make this first priority? How can we make this be successful and everybody walk away and feeling good about this practice so that they're willing to engage in it again?
I see. I think there are going to be a number of folks in the audience who might be excited about this topic. They might have clients or students that could benefit from some of these interventions, but they're kind of looking for, they haven't been formally trained. They haven't had the benefit of going to KKI like you and So what would be some advice for someone who wants to get more into this area, but they haven't had the benefit of graduate training or postdoctoral training and things like that? What are some ways that people can get started while maintaining, I guess, safety of the client as a priority?
Definitely. So I think the number one thing I think is reach out to folks in your community who do have some familiarity with feeding problems, and that very well may be, and probably may even be better to have a mix of disciplines within that. Feeding is a team sport, right? So we really want to make sure that we are consulting with folks with different perspectives, different disciplines, different skill sets and knowledge bases to be sure that we're looking at all of the different facets that come together to create a feeding problem. And so I think the more diverse your team that you're pulling from, probably the more skilled you're going to be at providing that support to the family. I think you could also go to feedingmatters.org. I mentioned that. I feel like I'm doing a plug, but they have a list of folks who do feeding, like a listserv. And, maybe reach out to a behavior analyst or psychologist or someone that could provide some mentorship or support to you. Or you could just say, hey, can I just pick your brain about this real quick? So I think creating your team, and then if, depending on your comfort level and familiarity with that, also maybe looking to see, is there somebody in your community that you can relate to and look for supervision? Behavior analysts really have a lot to offer, because we're really good at fading and shaping and generalization and caregiver coaching. And those are all extremely important aspects to the treatment of pediatric feeding disorders, right? And so if we could team up with folks who know these other pieces that we have less familiarity with, I think that could be really powerful, right? And just making sure that you feel like that you have the supervision needed to kind of help guide that path for you.
Very good. Very good. Well, I have certainly learned a lot in this conversation. So I appreciate you coming in and especially talking about the non-behavior analytic angles to this, because, I think most of us can pick up Java and read some of these articles and, we have the background, or at least the terminology to grapple with some of the established literature, but a lot of the factors that you mentioned are just way beyond our the typical behavior analyst current understanding. So I found that particularly helpful and enlightening for sure. I want to give you an opportunity if there's anything else about feeding that you'd like the audience to know, and of course, I'd like to wrap up like we always do with advice for the newly minted BCBA. So I'll let you kind of take us out from there.
Okay, I guess the two biggest things is making sure to really be able to communicate with your with the family and understand what their goals and kind of where they see the barriers. As I mentioned, we have lots of ideas, cultural ideas or individual family ideas about what should be. And I think really respecting the priorities and goals of families and having that be the guide of how you progress with treatment is really important. I've seen a number of children who are receiving lots of different services, and recently had a family remark that they felt like they were receiving ABA service, they were receiving speech, they were receiving OT, but they felt like that nutritional aspect or lack of getting that treated and being able to really come together as a team and figure out how we're going to do this together. Once that happened is when all the other skill acquisition things came aligned, right? So not underestimating the power of having good nutrition and good, getting the intake that children needs to be able to make sure that they are ready to learn and they're ready to benefit from all these other good programs that you're putting in place. And then finally, making sure that as you work with your patients who have these concerns, creating your own team in your community, reaching out to other folks. I think folks want to engage. They want to learn from what you have to offer, and doing so responsibly by seeking supervision when you need it.
Very good. All right. Melissa Gonzalez, thanks so much for joining me.
Thank you. Thank you for having me.
Thank you for listening to the Behavioral Observations Podcast with Matt Sikoria. You can find Matt's notes on this episode at www.behavioralobservations.com. We also invite you to stay connected with us on Facebook at facebook.com/behavioral observations and on Twitter at Behavior Podcast.